Medical Lecture, Acne Vulgaris. Introduction. Acne vulgaris is a prevalent chronic skin disease that involves blockage and/or inflammation of pilosebaceous units, hair follicles, and their accompanying sebaceous glands. Acne can manifest as non-inflammatory lesions, comedones, inflammatory lesions, papules, pustules, nodules, or a combination of both. It primarily affects the face, but can also be found on the back and chest. Background. Acne vulgaris is the most common skin disease in the United States, affecting around 80% of Americans at some point in their lives. Approximately 20% of those affected experience severe acne, which can lead to permanent physical and psychological scars. The disease typically affects areas of the skin with a high density of sebaceous follicles, such as the face, upper chest, and back. Pathophysiology. The development of acne vulgaris is multifactorial and primarily influenced by genetics. The key factors contributing to acne include 1. Follicular epidermal hyperproliferation. This leads to the plugging of hair follicles. 2. Excess sebum production. Sebum is an oily substance produced by sebaceous glands. 3. Cutibacterium acnes, C. acnes. Colonization, formerly known as Propionibacterium acnes. This bacteria plays a crucial role in acne development. 4. Inflammation. Inflammatory responses can precede hyperkeratinization and contribute significantly to acne pathology. Inflammatory responses. Inflammatory mediators are released into the skin, triggering the activation of local endothelial cells and upregulating inflammatory mediators such as VCAM1, ICAM1, and HLA-DR around the pilosebaceous follicle. Follicular hyperkeratinization. This involves increased keratinocyte proliferation and decreased desquamation, leading to microcomedones filled with sebum and keratin. Role of C. acnes. C. acnes stimulates inflammation by producing pro-inflammatory mediators that diffuse through the follicle wall, activating toll-like receptor 2 on monocytes and neutrophils. This results in the production of pro-inflammatory cytokines, including interleukins 12 and 8 and tumor necrosis factor. Sebum production. Sebum production is regulated by hormones, particularly androgens. Increased levels of adrenal androgens, such as dehydroepiandrosterone sulfate, DHES, correlate with the severity of acne. Other factors, including growth hormone, insulin-like growth factor, and corticotrophin-releasing hormones, also influence sebaceous gland activity. Etiology. The primary cause of acne is genetic predisposition. However, several aggravating factors can exacerbate the condition. Cosmetic agents and hair pomades. These can worsen acne. Medications. Steroids, lithium, antiepileptics, and iodides can promote acne development. Endocrine disorders. Conditions like congenital adrenal hyperplasia and polycystic ovary syndrome PCOS can trigger acne. Mechanical occlusion. Items like headbands, shoulder pads, backpacks, and underwire bras can aggravate acne. Sunlight exposure. While excessive sunlight can flare acne, ultraviolet exposure also ages the skin. Signs and symptoms. Acne vulgaris is characterized by non-inflammatory, open and closed comedones and inflammatory lesions, papules, pustules, nodules. It primarily affects the face, upper chest, and back. Local symptoms may include pain, tenderness, or erythema. Systemic symptoms are usually absent, but severe cases can lead to conditions like acne conglobata and acne fulminans, which may present systemic symptoms such as fever and joint pain. Diagnosis. The diagnosis of acne vulgaris is primarily clinical, based on the presence and type of lesions. 1. Comedonal acne. Open and closed comedones with no inflammatory papules or nodules. 2. Mild acne. Comedones and a few papulopustules. 3. Moderate acne. Comedones, inflammatory papules, and pustules. 4. Nodulocystic acne. Comedones, inflammatory lesions, and large nodules greater than 5 millimeters in diameter, often with scarring. Laboratory tests. Laboratory testing may be indicated in specific situations. PCOS. In female patients with oligomenorrhea, hirsutism, and/or acanthosis nigricans, tests should include total and free testosterone, DHEAS, androstenedione, luteinizing hormone, and follicle-stimulating hormone values, as well as a lipid panel, glucose value, and insulin level. Refractory cases. For cases unresponsive to long-term antibiotic treatment, culture skin lesions to rule out gram-negative folliculitis. Management. Treatment aims to address the 4 pathogenic factors: follicular hyperproliferation, excess sebum, C. acnes, and inflammation. The choice of treatment depends on the severity of acne. Pharmacotherapy. Medications used in treating acne vulgaris include 1. Topical treatments: erythromycin and benzoyl peroxide, clindamycin and tretinoin, azelaic acid, benzoyl peroxide, topical dapsone 2. Retinoid-like agents: topical tretinoin, adapalene, tazarotene, isotretinoin. 3. Antibiotics: tetracycline, minocycline, doxycycline, sarecycline, trimethoprim sulfamethoxazole, clindamycin, topical erythromycin, minocycline, topical foam. 4. Hormonal treatments: spironolactone, selective aldosterone antagonist, clascoterone topical, androgen receptor inhibitor, estrogen-progestin combination oral contraceptives. Topical or systemic antibiotics should be used with benzoyl peroxide to reduce resistance. Pharmacotherapy. Dietary modifications, such as a low glycemic diet and avoiding junk foods, can help manage acne. Skim milk has been associated with acne. Procedures. Procedural treatments for acne include 1. Manual extraction of comedones. 2. Intralesional steroid injections. 3. Superficial peels using glycolic or salicylic acid. 4. Light and laser therapy. Epidemiology. United States acne affects up to 50 million Americans annually, with 20% experiencing severe forms, leading to permanent scarring. International cystic acne is prevalent in the Mediterranean region. North American whites have a higher prevalence of acne, while African Americans have a higher prevalence of pomade acne. Race acne is common in various ethnicities, with darker skin more prone to post-inflammatory hyperpigmentation. Sex acne vulgaris is more common in males during adolescence and in females during adulthood. Age acne can occur at any age, from neonatal acne to adult acne. Neonatal acne usually resolves spontaneously, while adolescent acne affects 85% of people aged 12 to 24. Adult acne is increasing, affecting up to 12 to 15% of women. Prognosis. Acne can cause long-lasting psychosocial and physical effects, including depression and anxiety. Permanent scarring can be difficult to correct. A 2017 Swedish study suggests that teenage acne may be a risk factor for early prostate cancer, possibly linked to C. acnes. Acne generally clears by early adulthood in men, while adult acne is more common in women. Patient education. Patients should be informed about their treatment regimen and potential side effects. Retinoid dermatitis may develop around day 10 of therapy. Skipping a day or two and restarting slowly can help the skin adapt. This comprehensive overview of acne vulgaris covers its pathophysiology, etiology, diagnosis, management, epidemiology, prognosis, and patient education, providing a detailed understanding of the condition and its treatment.